Hello, good afternoon. First of all, I would like to thank the organizing committee for this very kind invitation. And the topic we're about to discuss in the next minutes is about how to detect high-risk and vulnerable plaque by intracoronary imaging. To start with, it's one thing, the symptoms, it's another thing, the vulnerability of the plaque. Two totally different equities. So, our armamentarium gets bigger and bigger with interventional and non-interventional modalities. If we keep the interventional, we have the OCT, the IVUS, and the modalities that are combined with IVUS, meaning NIRS IVUS and RF IVUS. So, what is our goal? To detect the famous TICFA, thin cap fibroatheroma. And if you see this definition, it's quite large, and we should keep in mind that the two things, large lipid-rich necrotic core and thin fibrous cap, as we may see in the next slides. Of course, when we talk about vulnerable plaque, we should never left unmentioned, especially here in a Greek Congress, our Greek legacy from the University of Athens, and the first trials trying to assess the vulnerability of the plaque and opening the way for future trials and more pioneers. So, intravascular imaging evaluation. The three major modalities. First of all, let's start with the right one, the OCT. The OCT can assess the thin cap fibroatheroma by measuring the cap itself, and if it's, the literature says less than 65 microns, it's supposed to be a thin cap fibroatheroma, and we may see the lipid core as well, not as well as with the IVUS because of the less tissue penetration. With the IVUS, we can assess the plaque burden, the lipid core, and if we combine the IVUS with the near-infrared IVUS, we can be much more sensitive for fat and lipid core, and we can assess and quantify exactly with the NIRS chemogram the maximum lipid core burden index, meaning the fat itself. If it's above 400, it's supposed to be a high lipid burden. So if you take it one by one, this is a classic thin cap fibroatheroma, especially on the right-hand side, we can see a thin cap with a large necrotic plaque fully infiltrated with macrophages, as we saw in the previous talker, Mr. Katsianos, and we need to avoid this kind of things, this rupturous plaque, and this is all about plaque vulnerability to avoid ruptured plaques and acute coronary events. With the IVUS, we have much tissue penetration, much more tissue penetration, but less spatial resolution, so we cannot assess the thin cap, but we can see with this eccolucent plaque that is the lipid core, and we are able to see necrotic plaque as well as this huge necrotic plaque here that is very vulnerable, and it is possible to lead in future events, and we must be much more aggressive. So the combination of the IVUS are those two. On the left-hand side, we have the NIRS IVUS, as we saw before, with an IVUS run, and as Dr. Kalogeropoulos sent us, we can see the LBCI index and quantify the lipid and assess the vulnerability of the plaque. On the right-hand side, we have this thing, the RF IVUS, other called as virtual histology, as we take advantage of the properties of each tissue to absorb or deflect radiofrequency, and then identify and characterize each tissue separately. So with the RF IVUS, we can see which tissue is necrotic, which is lipid, if it's fibrotic or calcified, and see the thin cap itself. And this is the only case of IVUS that can identify thin cap fibroatheroma. Not that well as with OCT, but it can identify thin cap fibroatheroma. And when we combine all the big trials that tried to assess the coronary imaging-derived variables for prediction of clinical outcomes, the one thing that is very impressive is the negative predictive value on the right-hand side. And if we talk about specifically the prediction trial that combined the use of IVUS and shear stress of the coronary artery, we have a relatively high positive predictive value. And of course, when we're talking about vulnerable plaques, we cannot left unmentioned the only so far high-level evidence that we have in our quiver, that is the PREVENT trial that was published last year, that says us if we treat the vulnerable plaques, things get better. So the investigators separated the patients randomly, either receiving optimal medical treatment or PCI as well. They identified non-obstructive epicardial coronary artery plaques with negative FFRs and with positive lesion characteristic of high risk burden. So we see MLA, plaque burden, TICFA by OCT or RF IVUS, and LCBI above 315 with the NIRS IVUS. And then, as far as the secondary endpoints concerned and the primary as well, PCI did much better than optimal medical treatment. Of course, we should keep in mind that almost half of the patients were treated with the Absorb platform, the bioresorbable Absorb platform that was removed from market in the middle of the trial, and that's why the investigators changed their way to drug-eluting stents after the removal of the Absorb platforms. Thank you very much.
So, any comments from or questions regarding? I think in this case you used the PREVENT trial to put the stent. You had the black burden, which was really at the age of almost 70%, lipid-rich plaques and thick cap fibroatheroma according to the thickness of the plaque, of the intima. Any questions?
But we are the limit on the case. Why? Because in the PREVENT, the number one factor to decide to go ahead was MLA and not a thin fibrous cap atheroma. Also because they were investigating a stable population. And here the MLA was 4.25 or 4.3 millimeters square. But we know that when we are leaving at least one stent, this is a crucial value in terms of outcome. When you are going down to 4.5, you have a dramatic increase or exponential increase or target vessel failure. So I think that we were borderline with this value plus a thin fibrous cap atheroma defined by OCT. Any comments?
Well, just to be the devil's advocate here, so I'm still not convinced that the angina that he had, this patient, was due to this lesion. So we didn't investigate vasospasm, vasospastic angina, other factors. We saw that it was TIMI2, as you said, 2 to 3, the flow. So probably, maybe, we place a stent, but we don't know if we did the correct action. So in this trend, we know that this is modifiable, the plaque is modifiable. The patient can stop smoking, can increase lipid management, to do better things in these modifiable factors. So we wouldn't do that, honestly.
I agree. Okay, it's a vulnerable plaque. We put a stent. We are we show that probably the MLA it was not the right thing that we want to be, but the symptoms, the angina, what type of disease was an acute coronary syndrome? We didn't see some rupture of the plaque. We didn't see a flow-limiting stenosis. The symptoms were from what? Were for like a vasospastic angina, was a stable angina for the cold of the feeling cold of the patient. I don't understand what was the reason of the angina.
We didn't have the evidence of the flow-limited lesion, but we had the evidence to get a lot of a plaque burden that was a fibrous atheroma, and perhaps with the changing the vasomotricity, it can make also smaller the lumen that was already below the limit that we know is going to induce potentially flow-limited impact. Okay. Any other point or question from the audience? Okay, please, go to the microphone.
I think that what we're thinking is that it's a different patient, a patient with ACS and other mild to moderate stenosis with valvular plaques than the chronic coronary syndrome patient or a stable patient. And I don't know if maybe in the future we will change our mind about this to find only the valvular plaques and don't care about the patient clinical profile. But until now, I would be more confident to send a non-carpal region to an ACS patient with valvular plaques, but to send a chronic coronary syndrome patient or a stable patient. Okay, I don't know if you have thoughts about it.
Okay, I think we should go on. I mean, it's a borderline case.
It's a longer conversation, and
it's a
But
borderline
at least
case.
we discuss a lot about what is vulnerable, where we are,
I think
what
it's
do
a
we have
borderline,
miss, inflammation, all these things, the physiology, the impact of hybrid technology. The next section is going to be on the future, and we saw a lot of hybrid technology, IVUS, NILS, and so on.
So let's go to the last case.